Good afternoon and welcome to Scientific Sessions 2012. I am Donna Arnett, President of the American Heart Association, and I'm joined by three wonderful colleagues to discuss the important presentations this morning for prevention. So with me I have Dr. Bill Zogby from the ACC, who is currently President, Dr. Sid Smith, President of the World Heart Federation, and Dr. Odo from Turkey. So welcome, and let's get started.
Thank you.
Great to be with you.
So Dr. Otto, we had two very interesting but quite negative publications this morning on fish oil supplementation. So can you describe the forward and opera trials to us?
Thank you very much. There were two important trials, randomized control and in a very large scale. And the forward trial was on the prevention, or actually secondary prevention of atrial fibrillation in patients with paroxysmal and persistent atrial fibrillation. And the OPERA trial was related to the prevention of postoperative atrial fibrillation by omega-3 fatty acids. Actually, the story of omega-3 fatty acids is a long one, and it started with the bench, with the basic science evidences. We have a lot of evidences actually showing the effects of omega-3 fatty acids on the left atrium and even on the PV triggers, pulmonary arterial triggers, venous triggers, and also some other effects on inflammation and oxidative stress. And of course, there are some clues coming from the epidemiologic studies showing that if you eat, more fish, then you get less atrial fibrillation. And based on these, there are a lot of different scales, usually small, in heterogeneous population studies with different dosages of fish oil or omega-3 fatty acids, with different ratios of different fatty acids, and with mixed results. So these two trials were important actually to test and to see and to solve the problem of all these controversial results from the other trials. In fact, forward trial was a neutral one and did not show any difference in terms of prevention of atrial fibrillation by omega-3 fatty acids. If you take 1 gram per day, it doesn't give any benefit to you for the prevention of atrial fibrillation. And in OPERA trial, again this time with a loading dose of 10 gram and then 2 grams per day during the perioperative period, did not show any benefits of prevention of perioperative or postoperative atrial fibrillation in those who undergo to the cardiac surgery.
So Sid, what do you think? Do you think it's time to give up on fish oil for atrial fibrillation or not?
I think when it comes to atrial fibrillation, we have no real evidence that at least perioperatively taking fish oil makes a difference. Now you can say, what about a larger dose? Or maybe there's a subset of patients that we operate on where it would be effective, but I would not jump into a widespread guideline recommendation to use fish oils at this point. And I think it needs a little finer evaluation if we're going to go forward at all in terms of atrial fibrillation.
And it's a big industry right now, Bill. I know that they were pleased to find no bleeding side effects. So how important is the bleeding risk, and should we be worried if patients are still continuing these large doses of fish oil in the absence of no benefit?
I think we have to acknowledge that these are very good run trials. And they showed, one of them could be looked at from a safety point of view, and we did not see a negative safety signal, although from a thromboembolism point of view there was some effect there, and I think this is important to look at. However, going back to the atrial fibrillation prevention, even in the peri-op or maintaining of sinus rhythm, these are very well conducted studies, and we did not see any even trend going in that direction. So,
but I think at least at this moment, we cannot really recommend at least for the prevention of postoperative atrial fibrillation, to use, yeah.
But there are other areas. Save your
Yes.
fish oil to lower triglycerides. We have
That's what I'm going to say. As you remember, the primary indication.
Yeah, that's why I tried to limit myself for the
hyperlipidemia, so we can't forget about that.
Yeah.
So Sid, we also had another interesting prevention trial, a second follow-up phase of the Physicians' Health Study. So why don't you tell us about that and what they found?
Yes, Donna, a very interesting trial. Physicians' Health Study has taught us a little bit about aspirin in this group of folks. They're physicians over the age of 50, largely healthy. They less than 4% smoke. They eat 4 or more fruits or vegetables per day. They exercise, and they're pretty compliant with their pills. They take their medicines. And so this was a continuation of the initial physician health study using multivites. Now it's an important question because a third or more of the adult US population takes multivites, and we're spending roughly $5 billion a year. It'd be important to know what we're getting out of this investment. And they looked over an 11-year period with more than 14,000 physicians at a variety of cardiovascular outcomes and found no benefit. Now, there's only one very slight benefit in 27 versus 43 physicians in terms of total mortality from total MI mortality. That's thought to be a play of chance. So in contrast to the recent publication where there was a suggestion that multivites actually lower the mortality from total cancer, nothing in terms of heart disease. Limitations.
I think these are very, very important findings in terms of how we recommend supplements to the U.S. population.
Very, very important, but we don't know, for instance, there are no women in the study. We don't know, we assume these people were healthy. What if we took a group that were not at a good nutritional status and gave them a multivite? Opportunity for future research, particularly in developing countries where we have large groups of people that do have nutritional deficiencies, and the largest morbidity and mortality from heart disease in these countries. Would a multivite help if you're nutritionally deficient?
So, Dr. Otto, you're burning to address that question.
Actually, I would like
you.
to have one question and to have your ideas or to have your attitude under the light of the PHS2. To whom would you really prescribe multivitamins or suggest?
I don't think we have evidence that multivites would help anyone who is not nutritionally deficient.
This is important.
I think if we have a nutritional deficiency, then you could argue, correct it. And if you can't do it with diet, which is something we can come back to, the importance of diet, then a multivite might be helpful. If you have somebody with a family history of cancer, I don't know how that enters into it, because we're cardiovascular folks, and there are some data looking at cancer. I think we need to know more about that. But from heart disease, I'd be focusing on the Simple 7 that American Heart has put forward as a way of preventing cardiovascular events, not taking a pill.
So, Bill, I know that you have an opinion about this as well, don't you?
I think, if you look at the population that was studied, it pertains to the three of us here among the four. So physicians who are overall healthy, who take care of their cardiovascular lives, they exercise, they had an incredible diet. Good thing is that there were no negatives, at least from my point of view, to the trial. So if there are positive signals from a cancer point of view or other things that we could take. So we could, and I agree with you, Sid, regarding if individuals have nutritional deficiency, particularly when you take it outside the world and to the big population, these are very important. So for cardiovascular risk, if individuals are overall healthy and taking care of themselves, multivitamin is not going to add further prevention to that.
So let's move to our last study, and that is the Umpire study, and this is the polypill discussion. So tell us a little bit about that study.
This is a very important trial, and the reason for it is it may not necessarily apply to all the populations, but if you just put in mind that there are 3 billion people who don't get good cardiovascular care that conceivably at a low cost and with a formulation that addresses all risks from aspirin, statins, and blood pressure, that conceivably we could impact that. So this trial was interesting in, it doesn't address all that, but it addresses a population where individuals are already taking medications for cardiovascular. So this is a higher risk population already to start with, or known coronary disease, that are taking either usual medications or put on a poly pill. And the outcome is not really cardiac events, but is compliance as well as reduction in cholesterol as well as blood pressure.
So
And
it helped compliance, right? That's the bottom line.
It helped
from the Empire
compliance.
study.
It helped compliance, and although the doses are less than the doses that were prescribed as usual care, the effect on blood pressure as well as on cholesterol were more significant. So it tells us that using this combination, it looks like it was safe, but at the same time more effect on risk factors.
So,
Like a proof of concept.
yes.
Proof
Study.
of concept, and conceivably you could have much more effect, obviously,
Yes.
in a population that has not been taking medications and would be on the first.
And there's a long way to go in this, context.
So Sid, you know, I know you have a real interest in global health, as do I, and I'm curious. This is a population that was high risk to begin with, or had cardiovascular disease. I believe more than 80% had cardiovascular disease. How could this be rolled out in more resource-poor settings, or could it?
Oh, it's a very important trial, Donna. The World Heart Federation has endorsed multi-drug single pill therapy such as this. And there are a couple hurdles. With secondary prevention, very important that you can show that the surrogate markers are lowered in the same manner, that is blood pressure and total cholesterol, as if you took the pills individually. This trial shows that. Secondly, and importantly, we intuitively, the more pills you have to take, the less likely you are to take them. You need to show that. And this trial provides the evidence that people are more likely to take this pill, get the same results in multiple pills. It's very important. I'd like to know the cost. We heard a phenomenal presentation in opening sessions from Steve McMahon talking about how little people can afford medications. You need to know that the cost is there. If this pill is inexpensive, it's doing the right thing. Now, primary prevention, there's another hurdle, and that is you have to show clinical outcomes in primary prevention. Secondary prevention, we've established that lowering LDL, lowering blood pressure is efficacious. For primary prevention, we need to show, given the risk, that taking the pill actually reduces events. So it's a little different hurdle. And then finally, patients that do have stents in, none of them were included in this study, would have to add a clopidogrel type agent to the pill. And we're running into that problem in one of the trials we're looking at in Spain, Italy, Argentina, Brazil, and Paraguay. It's a 5-country that many of the patients are getting stents, and so that's not in most of these pills. But this is a good study with valuable information about adherence, which is better, the compliance, and the ability to do the same as multiple pills in terms of blood pressure.
Terrific. Well, I want to thank our panelists, Drs. Odo, Smith, Sogby, and myself, and thank you for your attention today.